I would request Dr. S.K. Mathur. Dr. S.K. Mathur is a senior physician, specializes in thyroid, a wonderful person in his own right, and a wonderful thyroid specialist. I would request him to introduce Dr. Viveka and to take the CME forward.
Thank you, Sushi. Viveka Kumar, who is a lifeline for this group. He has been, as Sushi already mentioned, they kept us going all through. And I like to compliment you, sir. Thank you for that and keep doing that. He's a wonderful and most competent cardiologist, interventional cardiologist in particular, we have been known so far. And he's been doing a wonderful job in Max Saket Hospital. Very popular as a cardiologist and a wonderful human being. What qualities he has is very difficult to express in person. I'd like to thank Dr. Viveka Kumar to be here with us all the while. Before wasting, sir, when I request you to take on this. Thank you.
Good evening, friends. At the outset, I would like to thank all of you for being here. So, before, at the last moment, as Dr. Chauhan said that, there is no sponsor, and I said which topic we should be discussing. He said we just discuss things, important things which has been done in last year, so that is 2018, because we are reaching the end of the year. So what we have done in last 1 year, so I'll just give a small glimpse of that, and that is all related to advances in cardiovascular intervention. So I'll try to keep things simple and short. So the size of the scar is coming down, and then the dream of an interventionist is to have no scar in their patient. So we say that anything a cardiac surgeon can do, an interventional cardiologist can do as well, or better percutaneously. So if we look at the evolution of interventional cardiology, the main paradigm shift and revolution in this field has been the percutaneous repair of the mitral regurgitation. Then we have started and endeavored in the field of changing the valve without opening the chest, that is called TAVR procedure or TAVI procedure. Left atrial appendage closure. Then a few years back, nobody could have imagined that a pacemaker can be implanted where there is no lead, no scar, and that pacemaker would be MRI compatible and would go on and on for almost 15 years. And only device in the world which could be compact, can be switched on and off with a Bluetooth. So Bluetooth compatibility is there. We are fortunate to witness the revolution. This is how an open heart valve surgery is changed. So the whole chest is opened, and then you could see that the aorta is open, and this is the aortic valve which is changed. So this is how conventionally it is being done. And you can see here, holding the right groin, and through this sheath of 14 French, this whole valve is changed, and the patient is under conscious sedation, means there is no anesthesia. After 6 hours of the procedure, the patient has started walking, and next day can be discharged. So there is so much of revolution as compared to this procedure where the patient has to be in ICU for 3 days, and then this patient would be discharged in 7 days. So if you look at the things which has really revolutionized the intervention is what we call imaging of the heart and the physiology of the heart, which is called fractional flow reserve in angioplasty, and then optic coherence tomography, which is the intracoronary CT scan. And then we do also, for many years we have been doing what we call intravascular ultrasound. So imaging could be in the form of optic coherence tomography, intravascular ultrasound, and then the physiology. So there's a lot of time when we go, and then people say, I visited one cardiologist, he said that this is a significant blockage, the other one says it may not be significant. So all those answers, whether it is significant or not, can be answered by the physiology of the artery blockage, which is called fractional flow reserve. Then the mitral valve interventions, we have been doing balloon mitral valvotomy or percutaneous mitral valvotomy for many years, but now without surgery, through a keyhole, it can be repaired also, which is called mitral clip. And then mitral valve replacement is now reality. So we have got Intrepid device, which is from Medtronic, and there is a large trial which is going on. So probably in another year or so, it will also be a reality, like TAVI procedure or aortic valve replacement. As I said, that we have been doing TAVI procedures or changing the valve. So we have got Medtronic 4 valve, and then Edward valve is there. There is a last week there was Indian valve, which is called My Valve from Marine Life Sciences. The government has given clearance to that also, and is now commercially available. So that is also one valve which can be implanted percutaneously. A lot of patients who have got atrial fibrillation get into risk of stroke, and because of the other comorbid conditions, they cannot really take oral anticoagulant. In those situations, we can close the left atrial appendage, because more than 95% of the clot sits in the left atrial appendage. So Watchman device is that which can do the job. And then we can similarly change the pulmonary valve, which is called Melody valve. This is again from Medtronic. Then a lot of young kids who have had the repair for tetralogy of Fallot or various cyanotic and other heart diseases where the pulmonary valve leakage is very common. And then in those situations, once they became adults, they would have to go for redo open heart surgery and change the pulmonary valve, but we can percutaneously change the Melody valve, so we have done many of them here. And then leadless pacemaker, as I said, it's again a revolution by the American Scientific Society. It is considered a revolution of this century because this is just a 2 millimeter capsule which can be just dropped in the right ventricle. And then subcutaneous ICD, which is everything is outside the heart, there's nothing goes inside the heart, and no venous uses is there. So this is again a revolution where the patient would not be needing, so those patients who have had issues of vein, those who are on dialysis, those who are young patients can utilize this. Then the heart failure is the final common pathway of all cardiovascular disease. If the cardiovascular diseases do not get treated in time, then they will go in at the end in the heart failure. And you can see that the heart failure is the most serious problem, and you need to go to heart transplant. Or if you look at the problem with the heart transplant is that the person, every one of us has got only one heart, unlike kidney where one can donate one kidney, or unlike liver where part of the liver can be donated. So the heart transplant is a big problem. So in that situation, the artificial heart or left ventricular assist device is a miracle. And then, so first coming to the physiology of the arteries. You can see this is one of my patients who has had coronary angiogram done somewhere else. He was told that his arteries have got moderate blockage, so right coronary artery, you can see there is a narrowing, but it doesn't really look to be very significant. And then he had another blockage here in LED, and which also did not look significant, and he was discharged from there, and he was told that it's all the non-cardiac chest pain, but it was very classical angina. So he said that what should I do? And so this is what we did. You could see this is the FFR wire, and this is how the pressure tracings would look like. I don't know whether you can see from a distance, but it is basically a pressure difference between the proximal part of the artery and distal part of the artery, and based on that ratio we take a call whether the blockage is significant or not. So you can see this is how the tracing would look like, and it automatically calculates. So when we look at the right coronary artery, the borderline blockage looked like, and then any fractional flow reserve ratio of 0.8 or below that is considered to be significant, and that blockage has to be treated. In this artery, when we did the FFR of right coronary artery, that was 0.85, so it was not significant, and we did not really treat that. And the LED, which looked like moderate blockage, when we did the FFR, you could see that showed 4.77, and that was highly significant. So meaning thereby that this patient had true angina, which proved by physiology, and we did. So this is a case which we were doing a live case, 3-4 weeks back, and then this is a real learning for a lot of young cardiologists that you cannot just brush off. So you need to use the imaging and the physiology in the lab so that you give the proper treatment to the patients. This is again the optic coherence tomography. So this is again the you could see the same patient where we have done. So this is how the still frames of this is the longitudinal section of the optic coherence tomography, and this is how the images would look like. So we had optimized the. So this showed that the patient had, for some reason, I think the images are not playing, but nonetheless we'll just use the still frame. So after the angioplasty in the same artery, the LED, we did. So we need to prove that after doing angioplasty, the patient had benefit. So after post procedure, you could see the FFR became almost normal, 0.94 from very highly significant stenotic value of 0.77. So you can imagine it is like proving that the patient had real benefit after that. Mitral valve interventions, as I said, we have been doing the percutaneous mitral valvotomy for many years, and so this is the place from groin. We go inside the heart from the vein. It is done under local anesthesia, and then this is how through the venous system we go all the way inside the heart, and then we puncture the left atrium. So this is how the interatrial septum is there, and this is how the stenosis mitral valve is there. So this is a simple procedure. Under local anesthesia, we go all the way in, and this is a balloon which is dilated across the stenosis mitral, and these are the two commissures. Once the commissures give way, the valve opens, and the beauty of this procedure is that the patient does not need any anticoagulation and all, does not need any antiplatelet, and it works for rest of life in 30% of the cases, and then it can be repeated if the recurrence happens. As I said, the mitral valve repair is Achilles heel, because if you don't repair and replace the valve, the patient would need oral anticoagulant, and the surgeons need many years of training to repair the valve surgically. But it's a wonderful thing that without opening the heart, we can repair the valve. So this picture you can see, this is how an echocardiography, this blue jet looks like an regurgitant volume. So, and this is the ventricle, this is the redundant valve. So what we do is that this is a mitral clip. So with the mitral clip, we can clip the mitral valve from single orifice becomes twice, double orifice. But the problem of leakage gets over, and it is done under echocardiographic guidance, and then this is how the final picture would look like, and the patients become really good. So recently we had a COAPT trial which showed that it decreased the mortality, and these patients really benefit from this procedure. This is again a 3D echocardiography of the mitral valve, and so this procedure we do under transesophageal echo guidance. This is the mitral clip, and this is the 3D reconstruction of the valve which is done. So this is also again now approved in India on what we call compassionate ground. So we usually import the device from Abbott Vascular. Then, as I said, the transcatheter valve in valve for mitral bioprosthesis. So if somebody has got a mitral valve replacement with tissue valve, then they're replacing the valve with another valve without opening the chest is very easy. So what we do is that we do a transeptal puncture, and they place new valve within the tissue valve. So the problem with the in non-operated valves is that the mitral inflow is pretty big. So there, seating a valve is a challenge. But if somebody has had a frame already implanted by the surgeons, and then if they have put the tissue valve, so remember, it can be done only in patients who have had a previous tissue valve. It cannot be done in metallic valve because there will be no place to implant this. So 10-9 transapical mitral valve. This is again a percutaneous valve, which is percutaneously it is implanted through the left ventricular apex and seated at the mitral annulus. So it's still under the trial. Aortic valve interventions is really well established. It's initially we used to do only in patients who are very sick, more than 80 years. The surgical risk is very high. But now it's been approved for even intermediate risk, those patients who do not have very high age, or those who do not have any other serious surgical risk. There also it can be done. And you would know that a lot of patients who were elderly, almost 30% of them would not get valve surgery done because they were having very high risk, very elderly. So to give these patients hope is that we do what we call heart team meeting in a patient who is suitable, and we have got hybrid labs. So all three components are essential for that, for deciding. And you can see that this valve is now approved in India. As I said, the latest addition to these valves is that there are two types of valve, which is balloon expandable, which is called Sapien valve, or the Merit Life Sciences My valve, that is again a balloon expandable. Medtronic core valve, it could be, this patient had what we call mitral valve replacement. This you can see, this is a metallic mitral valve seating here, and this is a tilted disc metallic valve. This patient was 60 years, but he had to undergo another valve, aortic valve over the 15 years of time. That had become severely narrowed down, and this patient was considered to be very high risk for open heart surgery, because as you would know, after one open heart surgery, there is so much of adhesions and there is so much of anatomical difficulty there that if you have to operate again, that becomes a real big issue. So in this patient, what we did is that percutaneously we had placed this Medtronic core valve, and you can see that this is a fully implanted valve, and we do it under the guidance of transesophageal echo, and the temporary pacing is required, because as you would know, there are a few patients where the patients can go into the complete heart block. And you can see this is again the transesophageal real-time images. This is how the valve would look like, and this is, you can see that echo, it is not fully expanded valve. So in these situations, we need to go in again and do the post dilatation. And those who can see from back, you can see before the procedure, the aortic valve gradient, that is the pressure difference between the left ventricle and the aorta, was very high. And you can see now after the procedure, this has become absolutely narrow. So there is no pressure gradient. So that's the beauty, that on table within minutes the pressure gradient becomes normal and the patient starts feeling really good. This is another patient who was 75 years of male who had recent angioplasty done, but his symptoms continued to be bad, and the other hospital said that the surgery is very, very high risk. So in this situation, these patients would really need. So this is, you can see that we first dilated the valve. This was very calcific valve, and this is the valve which is the Indian My valve. So this valve, we positioned it rightly and then implanted it there. So you can see that this is the implanted valve. But what had happened, that this patient's, I don't know, the pictures are not clear, but this patient had, because of the tissue which migrated into the left main, and the left main completely got occluded. So those patients who get left main occlusion, only 70%, 70% of the patients would die on table, because by the time they go to the cardiac OT, they are no more, because left main is a very, very serious business. So what we did is, you can see from here that we did an aortogram. I think unfortunately this picture is not playing, but that we identified it very early, and then we opened this valve. You can see there is a guide wire, and then we put a stent here, and immediately the patient's pressure came back and the patient was saved. So this is what we have said, and this is one of the award-winning cases in EuroPCR Paris. So this is so you need to identify the complications very early and act fast, because the time is very less. In aortic valve also, if the patient has got a previous surgery done, then we can put a valve in valve, that is, if the tissue valve has failed, then we can take another tissue valve on, like TAVI, and then appropriately, so this is the annulus of the previous valve, and we can place a new valve so that it starts functioning immediately, like in this picture you could see. So if you look at the in patients now where we were saying that initially they are not the cases for TAVI procedure like severe aortic regurgitation. So it was initially indicated only for severe aortic stenosis, but now we have been putting it in severe aortic regurgitation also, mixed valve reasons also, and the what we call the bicuspid aortic valve also. Initially, bicuspid aortic valve was a relative contraindication. Then coming to the other revolution is that percutaneous left atrial appendage. So as you know that this is the left atrial appendage. So anyone who goes into atrial fibrillation and has got more than one risk factor, they are at higher risk of stroke. So those patients should be given oral anticoagulant or NOACs. And if they have the bleeding risk or had a previous stroke, then we cannot give them NOACs, but they stand to be at a higher risk of repeated stroke. In these situations, we can use any of these devices and then close this, appendage, so that the clot remains there in the appendage, and this gets endothelialized. So the repeated risk of stroke is very, very less. Then percutaneous mitral valve, as I said again, this is a procedure where we go from the groin, go into the, from the RV, we go into the RV, then into the pulmonary valve, and this is the Melardi valve, which is a tissue valve. So this is how we take it in and implant it there. So the structural heart is going to be the future of interventional cardiology, because the population is aging and more people don't want open heart surgery, because the risk of open heart surgery, if you look at the mortality, that is anything from 2 to 10%, whereas during the percutaneous procedure, the risk is 0.01%. So that's a very, very low mortality risk. As I said, that the Micra or leadless pacemaker is a real revolution, and it is like, you can see this a small tiny, it is like a Bicosol capsule. This is sitting in the right ventricle, and it is a Bluetooth enabled device which can automatically and it's an MRI compatible also, and it has the advantage that there is no lead, there is no pocket, the risk of infection and complications are really low. So if you look at the implant success rates are almost 99%, and there is a significant 51% major complications are fewer, simply because there are a lot of steps which is required in implantation of the pacemaker which is not there. So the patient will not have a lead related complication, lead fracture or lead displacement will not be there, and then the pocket issues like pocket infection and all will not be there. So any patient, as of now the technology is matured only for single chamber, that is ventricular lead. So in this situation, single chamber, so those patients who need a single chamber pacing, there it is indicated. So this is how the the pacemaker would look like. These are the times which we hook in the right ventricle trabeculae, and this is where the threading wire is there through which we take it inside the right ventricle. And safety proven data is quite impeccable, almost 51% fewer complications are there. And these are the few cases where you can see this lady had 3 surgeries, cardiac surgery in past, and after this surgery where the mitral valve was replaced, she went into complete heart block and had complete asystole. So this is how this catheter would look like, and the Micra leadless pacemaker is sitting in this delivery device. So we take it in and we have deployed right here. So this is how on X-ray it would look like, and it starts pacing immediately. Then subcutaneous ICD is again a wonderful thing which has, so nothing goes inside the thoracic cavity. So everything is outside between the skin and muscle, and this is the ICD. So as you would know, the sudden cardiac death prevention, almost 99% effectiveness of the ICDs are there. And this is as good as transvenous, where we put the ICD here and through the vein we go and put the leads inside the heart. But here the subcutaneous ICD, everything is outside. So the patient's vein is not destroyed. The patient who needs dialysis can undergo dialysis. And these are the few trials like effortless subcutaneous ICD registry and so on and so forth that has shown that it's really effective. This is one of our patients who was, where we had implanted this device. You could see this is how it would look like on implantation. And so real-time X-rays would look like this. And this is the picture after the implantation. Cosmetically it is hidden between the axillary area, so nobody would know. So this is highly desirable in Western world, where the female patients are very conscious about the cosmetic results. So this patient is one of the doctors who himself was a cardiac surgeon in South Africa. So he had got it done. Obviously the Indian origin doctor. So this is how after the implantation this whole thing would look like. So this is a wonderful thing because nothing goes inside the heart, and you can see on that the patient, we induce the ventricular fibrillation on table, and it automatically senses and gives a shock. This is the shock wave given, and the rhythm comes back to normal sinus rhythm. Then all the devices can be monitored at home. So this is called home monitoring devices. So you need to keep one device with the patient. It's like an iPhone, kind of thing, and which receives signals 24/7. And if there is anything abnormal, can be transmitted on the email to the doctor, and all the data will get there. So that is why these guidelines also include that this should be remote controlled. And then, as I said, that the last but not the least is that the final common pathway of all cardiovascular diseases is heart failure. So we have shortage of heart transplant because the donors are far too less, because brain dead and road traffic accident people can only donate their heart. So you needed an artificial heart, and the left ventricular assist device is again something which is wonderful. Temporarily we can stabilize these patients with Impella devices or intra-aortic balloon pumps, but those are not things which can remain forever with the patients. So this is how these devices can be used at the bridge to transplant also, like patients, once he gets the suitable heart, the bridge, their heart can be, and then left ventricular assist device can be removed. And so this is how from externally, this is the battery console of this. So one recently we have done one young girl, which is a 7-year-old girl from, Uzbekistan. So this is a patient who, so this is first case in Asia Pacific where you could see that the patient has had LV assist device, and she is now, almost 5 days post procedure. This picture is 3rd day post procedure, and now she is shifted in the ward doing normal activities. So she is a young girl who had, who couldn't get out of the bed. Now she is playing around, doing normal activities and all, and next week probably will be discharging her home. So this is a first of its kind in Asia Pacific. There are only 5 cases across the globe that have been done, and this family is quite affording. Older, and then once she gets a heart, probably she might go for heart transplant. But this is a device which can be as a destination therapy, also can work for 15-20 years. Some of these patients recover their heart, because younger patients may have recovery of the heart, and probably after 4-5 years we may not need the second left ventricular assist device. So to conclude, I would say the take-home points are that the percutaneous intervention, by virtue of their low procedural risk, represent a revolutionary paradigm shift in the management of patients with high surgical risk. TAVI or TAVR, mitral clip, watchman devices and MICRA have been evaluated in large randomized controlled trials and have been proven to have safety in appropriate settings, and further refinement in the technology and better hardware will result in outcomes equivalent to or better than the surgical modalities. So thank you very much, and for your kind attention.
With cardiology, the surgeons are given a back seat now, and I think it is going up and up, and revolution in the medical science is taking a big deal. Reducing the hospital stay, reducing the patient, I would say, muscle cut and all. That is very right. Thank you so much for updating us. Very nice. Questions from audience?
Very enterprising. So, CTFFR, the AHA-ACC 2018 said, stop doing daily cardiac catheterization for diagnosis purposes. Reserve it for therapeutic purposes. So CTFFR for diagnostic procedures, sir, for high-risk lesions, the CTFFR seems to involve the artificial intelligence. It's a slow paradigm shift for the future. So your word on that.
Yeah, so that's very good. So CTFFR, as you rightly said, is a good screening tool, like CT coronary angiography. This is a software from the Stanford company where you can put a FFR wire on a analyzing computer, and the point where you put, it will give an FFR value of that place. So it's as good as that. Having said that, the correlation with the invasive FFR is up to 70% at best. But having said that, there is still it's a very, very good tool, because 70% of the patients would not really need the intervention. The second thing is that a lot of patients used to be referred for bypass surgery, and also it gives what we call functional syntax score, where you can really know that the lesion is significant or not. So one of the problems is that if you go and operate on only angiographic finding, do a bypass surgery, many grafts would not work, and people would blame that apparently the surgeon did not do a good job, but it is not the surgeon's fault. It would be because the FFR value was not significant, so there was no pressure difference between the proximal end of the graft and the distal end of the graft. That is why the graft closed. So it is a simple physics principle. So you're right that the physiological information of the blockages is going to be the cornerstone in the management of coronary artery disease. As long as the physiology of the blockage is not significant, there is no advantage. In fact, there is a disadvantage of treating those blockages.
A recommendations is now a part of the algorithm of care in preventive cardiology. Sir, a word on that.
Yeah, so that's again paper which showed that. So this trial was done and published in Lancet, which included 10,000 patients who did the, so this trial included high-end CT coronary angiography. So all CT angiogram was done was 256 slice plus, and there it was shown that it predicted 10 years outcome of myocardial infarction. So that is the power of modern CT coronary angiogram. Because with this conventional coronary angiogram, you would not see a smaller blocks. with the stress thallium or stress echo, you will not see any plaque which is not hemodynamically significant. But high resolution CT coronary angiogram can see that, and it can predict the 10-year risk of heart attacks. And you can take a preventive action. You can take a high intensity statin therapy, you can take a PCSK9 injection, you can add ezetimibe, and you can add the blood thinner. So aspirin has been shown to be beneficial only in secondary prevention. Any patient who has diabetes also, now the recommendation is that should not be an aspirin, except those patients who has a proven plaque. So that is how it decreases the risk of heart attack by 30%. So that's a very good screening tool, and calcium risk scoring has been overpowered by what we call, coronary CT angiogram. And even in those patients who have had, initially, if they had a calcium score of more than 1000, the radiologist would say that, you're not suitable for CT coronary angiogram, but not now. Now we say that, okay, even if you have seen a lot of calcifications are there, look at the flow rate in distal part of the arteries. If the distal part arteries are filling adequately, it means that even if the calcium is there, but the blockage is not really significant or very tight. So in those situations, you can predict the outcome also.
So now a 2A recommendations. Sir, my final question. So a word on the intravascular lithotripsy, IVL, for heavily calcified lesions to prevent thrombosis, sir?
Yeah, so again, this is again a revolution in patients who have, and especially in Indian scenario where a lot of patients would have heavy calcification.
Yeah.
So as you would know, the calcium is called like it is, interventional cardiology, because you can't take your balloon, you can't take your stent, and the lesion doesn't give way. In those situations, we have old, method of doing a rotablator and then pulverize that calcium and then create a space and you can put a stent. But the rotablator would create a space only as much as the size of the rotablator is. So you have what 1.25 and 2 millimeter per maximum 2 millimeter per is there. So you can create a space of 2 millimeter. But imagine if artery is 4 millimeter, then you are left with no choice. You can't expand, so you can't put a stent, and then the risk of restenosis will be higher. So in these situations, these balloons, what is called lithotripsy balloons, these are nothing but a balloon which is, technology which is used by, urologists for renal stones. Same technology is used in this balloon. So this balloon is placed across the calcific blockage, and this, the balloon is connected to the lithotripsy machine and it is switched on. So with these ultrasound waves, it breaks the chunk of calcium. So there are cracks like a marble cracks, and then when you open the balloon, these lesions become dilatable. So these lithotripsy techniques are really wonderful, and so the cost is quite prohibitive. So it has not come into India yet. So it's a very, very revolutionary and treatment modality which could be used. So I think near future is going to come.
My last question, sir. So left and right bundle branch block now equal for urgent angioplasties in patients who have ischemic syndromes.
Yes, so new onset of bundle branch block is, so if you look at the what we call fourth international definition of myocardial infarction, so this has been included as a diagnosis in the recent European Society Cardiology guidelines, as that this is a new, that could also be considered as urgent, ECG changes. So this is called ischemic bundle branch block, and it should be treated as soon as possible.
Thank you, sir.
So, the FFR, whether real time or CT, how it stands compared to the TIMI flow? As you said, pre and post procedure FFR, changes in the FFR versus TIMI flow achieved. Which one is more dependable? And
yes, so FFR is definitely, if you have got 80% blockage, but FFR will be significantly. So FFR gives the physiology of that blockage, and TIMI flow can be, even in a critically diseased artery, TIMI flow can be normal. So whenever we do angioplasty, if you want to refine and give a best result, that can be achieved only by doing an FFR pre-procedure and post-procedure.
what about FFR of culprit and non-culprit vessels?
Yes, so basically, culprit in acute MI, as you would know, that you can't rely the FFR. suppose somebody has got an acute anterior acute coronary syndrome, there is a lot of thrombus burden and all, so the capillary gets choked. So there the FFR is of no use. But in non-culprit lesions, if suppose the blockage is 60%, 70%, then you are not sure whether that is significant or not. So you can do in non-culprit lesion. But in culprit lesion, you know, in the same acute setting, it is never reliable. So you should not be doing it.
Are we in very near future having generic valves? Generic valves. Like we have some generic stents and all that.
Yeah, so I think you'll be surprised to know that 110 companies are, you know, in the race to create their own valve. So there will be definitely some generic valve. Then these all tissue valves have a shelf life of, you know, the longevity could be anything from 10 to 15 years or at least 20 years. There is a company called Gore-Tex, which is an artificial skin company, and they have claimed that the longevity of Gore-Tex can be as much as a human being's life. So if they succeed in their, so this is like a tissue, you don't need to take oral antibiotics. So probably then the longevity of these tissue valves will also be very high. So there will be definitely, as the technology becomes. So when we started the tablet procedure, we started with almost 26 French. So we had to do surgical cut down of the joint and do from there. Now,
Home care of pacemakers. What does it mean?
home monitoring, the patient is given a catheter. So all the devices are enabled with home care facility now, the top line pacemaker, and the patient has to keep a device which is like a cell phone, and it can be 8 times, you know, every 8 hours it will interrogate the pacemaker. Now it has got a facility to find out the fluid overload patient is, whether it is in atrial fibrillation or not. So all these information goes to the central hub, and from there it gets analyzed. So caregiver would get all the information, and the alert will go to the patient also. So he need not come for the pacemaker checks every year or every 6 months.
Kind of FaceTime.
Yes, absolutely.
In case there is no acute event, and if you have
a person with a TMT positive, and we know a TMT can be false positive. So in case that person goes in for an angiogram, do you think it is prudent to do an FFR in all such cases to check whether it is actually so, or it is just something which is given a false positive?
So you're right in that so we say that angiographically, if it is less than 90%, then those lesions should have an FFR, because we have seen that any lesion, even sometimes almost 40% of the lesions who look like 75 to 80% may turn out to be negative FFR. So, and there is a lot of data, effort trial and all has shown that if FFR is negative, you are better off not touching that artery than doing anything. And in this situation, if you put graft on that artery, that graft may not flow. So that is a wastage of one of the arteries of the patient.
Stable or not?
So IVUS is not a tool where stability of the plaque can be predicted, but optic coherence topography, that is OCT, it is very good in predicting the plaque rupture, plaque instability, thickness of the plaque. So IVUS is slightly, resolution is less, so IVUS may not predict, but it is better than the plain angiography.
And secondly, earlier the biovascular scaffold went to a lot of disrepute. I attended a meeting where some of the leading people have been talking about the biovascular scaffold again being implemented and with a made in India perspective, blah blah blah, everything.
Yes, so in fact this case which I showed, I did 2 weeks back live case for the same meeting. That's Indian bioabsorbable scaffold. So this is called latest generation of bioscope. So concept-wise, absorbable stent was great, and still it is great. Only thing was that it has not matured. So the initial absorbed stent was stud thickness was higher, so that is why it took long time to resolve. So now there are 3-4 companies, almost 15 companies which are making. So out of that, 3-4 companies like magnesium bioabsorbable valve from Biotronic, Magmaris, and then the Viva valve from the company where it is visible also because it has got iodine in the tissue, and then the Maris valve from Merrill Life Sciences. So their thickness is just 100 microns, and that is why it gets absorbed within 2 years, and that is why it is better.
Because physiologically it obviously works better because if nothing remains in the artery, it is obviously a better.
So the best advantage of this is that the very late stent thrombosis is not there.
Yeah.
Still, the patients who had cipher stents, if they stop their antiplatelet, even after 15 years or almost 18 years after their implant, we still see that they come with a stent thrombosis. But those patients who have had this
Generation stents that you are implanting, how much of time do you do a DAPT minimum? 1 year or 2 years, and after that you can downgrade?
So all over all the metallic TS, up to still the guideline is for 1 year DAPT.
1 year.
And beyond that single antiplatelet. But we also look at the what we call DAPT bleeding risk score. If the risk score is high, then we even at 6 months we can make single antiplatelet because the current generation stents are. So it is a CE approval for single antiplatelet after 3 months.
So if a person is very high risk, for example, with all other comorbidities, with a very strong family history, do you personally consider that patient to be continued on DAPT for 2 years or more?
Yeah, so there is a 36 months trial data where, so if you look at the Pegasus data from Ticagrelor, there they have shown that if you give, up to 1 year 90 milligram of Ticagrelor twice a day, and then beyond that 60 milligram twice a day up to 36 months, the repeat myocardial infarction is lesser. And there was one very important finding that those patients who have got, the repeat heart attack, this is more often with non-stented arteries. So those patients who have got 30-40% blockages or 50% blockages, so they are more, and those events also come down if you give them longer duration dual antiplatelet.
Thanks very much. Thank you.
The cost is still almost 11 lakhs. So we have done around 25 cases here in Saket. So if you look at this, since it's available for last 3-4 years, it's a small number. Worldwide, one of the limitations of Micra is that why we don't do much is it is still a single chamber pacemaker. So most often it is the elderly population who do not want any scar and they don't want to stay in hospital for long. So we have done one of the world's oldest patients, 99 years of age, who is still live and kicking and has gone recently to Canada. So once it becomes a dual chamber, which will be by end of the next year, then probably the other pacemaker will get replaced. The cost is not a consideration.
Sir, my last question is, sir, you said, your journey through 2018 was about the advances in cardiology. So what is one advance that according to you stands out and will be a carry home message for all of us for 2018?
Yes, I think if you look at the advantage or advancements which is really being considered as the most revolutionary and which has established in itself in last year is the percutaneous valve implantation of both the aortic and the mitral valves. I would say that almost 30% of the population has come in the umbrella of getting treated. Otherwise, we would say that the surgical mortality is so high in elderly population that we would not be treating. So, if I have to rate one advancement, because Micra is already been given as a status of best revolution. But if you look at the number of people who are going to benefit from this therapy, it is the percutaneous valve technology.